University. Joined Bundelkhand University as assistant professor. There he served in various capacities. Professor in served as chairman, Commission for Scientific Technology, with additional charge of director, Central Hindi Ministry of Education, Government of India. Please bear with us. Some audio. Hello. Yes.
Hello, can you hear me?
Hello.
Yes.
Can you hear? Can you hear me? Can you hear us?
I certainly can hear you now. Can you hear me?
Yes, we can hear you. Okay.
Perfect. Okay, let me
All
see
right.
if I can increase the volume on my end.
Okay. Thank you, sir. So I have to start Professor Avinash Kumar's introduction from the beginning once again. Professor Avinash Kumar, Department of Mathematical Sciences and Computer Applications, Bundelkhand University, Jhansi. He has completed his MSc from CCS University, MPhil from IIT Roorkee, and PhD from Gurukul Kangri University. University of Roorkee awarded him University Medal for standing first in the first class. He has served as Assistant Scientific Officer in the Commission for Scientific and Technical Terminology, MHRD, Government of India, from 1995 to 1999. He joined Bundelkhand University as assistant professor in November 1999. There he served in various capacities and became professor on 26 November 2014. He served as chairman, Commission for Scientific and Technical Terminology, with additional charge of the director, Central Hindi Directorate, Ministry of Education, Government of India. He has supervised 14 PhD theses and 28 MPhil dissertations, and has published 95 research papers in national and international journals of repute. His research interests are modeling, optimization techniques, and distributed computing systems. He is a life member of IAPS, IMS, CSI, VPI, ORSI, and many other similar academic bodies and societies. Also, he is the vice president of ORSI and VPI, also fellow of VPI and associate fellow of IAPS. During 2010 to 2013, he was the head of the department. In his own department, he was the head. He was the chief of University Employment Information and Counseling Center, Ministry of Employment and Labor, Government of India, awarded the Model Career Center to this UEICC to facilitate the job seekers. He visited to the Rajmangala University of Technology, Thaniabari, Thailand, University of Science and Culture, Tehran, Kathmandu, Port Louis, Shanghai in China, Guadalajara, Mexico, for various academic projects. In 2000, he was awarded Professor R.C. Malhotra Best Teacher Award and Gold Medal for outstanding contribution to the university services by the Bundelkhand University, Jhansi. So we are privileged to have Professor Avinash Kumar chair this session on the third day of our conference. So now I request Professor Kumar to take over the proceedings.
Very good morning, all. Very good morning, Professor Sanjay Malhotra ji.
Yes, very good morning to you as well.
Uh,
Here it's late Friday night.
of technology, I welcome you.
Thank you.
The international conference on optimization, learning, and analytics in business, and also the 55th annual convention of the Operation Research Society of India. I feel honored in welcoming you, sir.
Thank you.
Professor Sanjay Malhotra is a professor of industrial engineering and management sciences at Northwestern University. Malhotra directs the Center for Engineering and Health within the Institute for Public Health and Medicine at Northwestern University. Malhotra's work uses quantitative, data-driven approach to support decision-making under uncertainty. His work involves statistical analysis and machine learning from data, operational modeling, optimization algorithms, development, and possible translation to practice. He is a fellow of the Institute of Operation Research and Management Sciences, Informs, and chair the 2022 Informs Fellow Selection Committee. Malhotra has given invited keynotes at national and international forums based on his work in optimization algorithms and healthcare system modeling, areas in which he has also taught courses. He has been department editor for the healthcare and optimization department of several journals. US federal agencies have awarded him more than 50 research grants. So we are honored in welcoming Professor Sanjay Malhotra ji. And today he's going to deliver the plenary talk on the stochastic optimization in healthcare. So with that, very humbly, I request you, sir, please deliver your plenary talk. Welcome, sir.
Thank you. Thank you for the invitation. Thank you for this very nice introduction. I hope you can all hear me.
Sure. Welcome, sir.
Very good. I know it's long distance. I wish I could be there in person. But partly our classes just ended earlier 3 days ago, and travel on a short notice with classes ending very close to the conference time was not practical, but I wish I could be there. And of course, as you all know, I have grown up in India. I've been in US for a long time. I am at Northwestern now for almost 36 years. But prior to that, I, of course, did my PhD at Columbia University. My undergraduate is from Roorkee. And that was back in 1983. So I do go back a long time in my life with fond memories of India. And then also I, just about every single day, maybe more than needed number of hours, I do watch Indian news. So I'm still very strongly connected to India. And my hope today is to try to give a sense of how I myself have evolved over the years. My career started in optimization methodology. And of late, I would say in the last dozen years or so, I have done quite a bit of work in the healthcare space. And as you will imagine, well, healthcare is a very, very important topic. So is optimization embedded all across different business domains. But today's focus hopefully will be illustrative and could be motivating to those in the audience to apply our operations research skills towards improving health systems and very pertinently health system in India itself. So with that, let me just try to share my slides, make sure that the slides go across. And once the slides are working, then I'll walk through the slides and I'll give you the outline of my presentation and hopefully end this in time.
Sure, sir. Welcome once again.
Thank you. So let me try sharing the slides. Just one second, because I'm going to share the screen. Are you seeing a slide deck here, which titles with something technical?
We are getting, sir.
Okay, you're very good. So I will go into full screen mode and I will scroll back quickly to the first slide. Just 1 second. So, as I promised, presentation today is going to be revolving around using stochastic optimization in healthcare. And given the nature of the talk, I will give you broad overviews of what is possible in terms of being able to contribute to the area of healthcare. We'll take a couple different nuances of issues that I have faced over the years while working in the healthcare with using healthcare data. We'll get a little bit more into the technical depth from an optimization perspective for those who know more about optimization. And then I'll hopefully close it with some work that led to the main, beyond the main part of the presentation I'll be making. So the work I'll be presenting, or at least the technical focus of the presentations, will be on something that I did about 6, 7 years ago. So this is not most recent paper, but what you'll see is that that paper was a pivotal research article, and the overall concepts as they came together became very pivotal to much of the future work I ended up doing from there. So I thought I could pick that up as an illustrative example. So I'm going to just talk about generally issues in healthcare and how operations research and management sciences can contribute to that domain. We'll look at issues about data quality and analytics, some of the problems that I faced very early on, and I'm going to just sensitize you on those things. I'll pick the specific example of staffing and scheduling, around which I will look at the stochastic programming modeling. I'll get a little bit deeper into the theory and the theoretical frameworks and what is expected and what is required when we try to solve these types of problems, and then subsequently looking at the value of bringing in more complicated methodologies in the domain, from not just from a research perspective, but also from a practical application perspective. And then finally, I'll step back and just talk about some generalizations of things that happened since, and conclude. And the way I'm thinking, given the long distance nature of the presentation, is that perhaps early on I can just speak in a flow, and then enough time will be remaining at the end so that I can address all the questions, if that's acceptable. All right. So stepping back, in healthcare, output is not profit. In healthcare, output is life expectancy, and input is money spent. That's the basic profit equation or productivity equation that you would like to see. And the figure here is showing, it's a few years old, but it's basically showing how dollars get spent across different parts of the world and the corresponding life expectancy. So singling out India here, the life expectancy right now is around 65 plus minus years, with very little per capita income spent towards healthcare. On the other extreme, if you look at US, we have upwards of $10,000 per capita spent per year, whereas the life expectancy goes say somewhere closer to 78, 79 years. We have countries that are spending much less, whereas the citizens are living longer on the average. And then there are obviously countries that are spending, comparable to US, living more. Countries where population is living comparable to US, but spending a lot less. So we have all these, all of these different spending longevity points that you could see on this curve. The takeaway here is, again, I picked two extremes: US spending a lot more, but not getting as much value on the dollars spent. India on having a lot more potential for living, for people living longer, assuming more can be spent, so that one moves along the curve. So as new government plans have been put in place, one will hope that over a period of time, as the money gets spent more efficiently and effectively, life expectancy of the general population improves. Now, this slide is basically saying that, well, I mean, I use India and US as examples, but across the different nations of the countries, different nations of the world, we have different disease dynamics that plays out. Within a particular country, different population subgroups may be actually having a different disease dynamics in terms of the main cause of mortality for those in that country or within that subpopulation. Okay. Just to give you a sense, right? We talked about dollar per capita. We talked about longevity. Obviously, we all want to live longer. Just to think about the scope of this, again, this slide's from a US perspective, about $4 trillion per year is spent in healthcare, of which about $300 billion to $1 trillion can be thought as a waste. Okay. In US, the life expectancy varies depending on what part of the country one is living in, but as many as 10 years. And we saw the previous slide where the life expectancy was varying almost 20 years across different countries. And that's not even incorporating some of the other South African countries where the life expectancy is even lower. Okay? So if you look at the data on the left, there's obvious conclusions on the right in this slide. Healthcare is big. Lots and lots of people are involved. Lots of clinicians, nurses, technicians, technology, and other players that are actually influencing the health system. It is a very complex system, and I think we can relate both India and US in this setting, where in US we have sort of a mixed payer system where some of the payments come from private insurance, some payments come from government, and a blend of the two. Whereas similarly in India, you have a lot of privately covered individuals where people are just spending money from out of their pocket to get healthcare services. And then a large portion of population more or less depends on government supported health infrastructure. It is complex, and complexity is from many, many different angles. From an information perspective, there's a lot of information that needs to flow across system components. And overall, as you could see the previous slides, we certainly can be improving this system. Okay. So again, from a very big picture setting, what are we looking at? We're looking at problems that have operational feature to them, that have policy connotations. We have issues about preventative care, and we have issues that are involving clinical decision-making. Okay, so if you look at those broad 4 buckets, within those 4 buckets, or even cutting across those buckets, we have decisions that are to be driven through data, and using data. These data are either being used within an analytical environment, or more relevant from an OR perspective in the modeling environment, where the model incorporating data will then lead to hopefully improved decisions. And these decisions could be of many different types. Could be hospital operations decisions, emergency response, budgeting, payments, ensuring equity across different population types, improving logistics and supply chain, overall resource management, maybe doing real-time care delivery, modeling of disease spread, for example, in case of pandemic, like COVID-19, diagnostics, delivery of therapy, and so forth, right? So we have all these application domains where the applications are then driven through the core concepts of data models and decisions. And around it, we have all these technologies that are I would say either computer science, information technology type technologies, or data science and decision science technologies like optimization, simulation, decision analytics, and so forth. Okay, so stepping back, we have a decision framework in which we want to be operating, in which we have data. We can be analyzing from data, from which we will learn. We can then using the two together to parameterize models. These models may need further mathematical analysis because they may turn out to be somewhat complex for them to be realistically solvable. And then finally, from there, we come back with decisions. Okay, I'll give you kind of some sprinklings here. So this particular issue is about just data, and a couple of slides here just to give you a sense, right? So for example, I was dealing with a problem here almost like maybe 8-10 years ago, where where I was very interested in modeling sudden death, where a person goes through a cardiac arrest, and the survival probability of a person going through sudden cardiac arrest is very low, say 1%. So the idea is that if we can predict this onset of sudden cardiac arrest, either we can intervene it early through, say, a implantable like pacemaker, or because we know that that's needed, or we can intervene it on the site or monitor a patient more closely. Implantation of the defibrillators is very expensive, so we can't just be implanting those things willy-nilly. We want to be screening the patients to make sure that those who actually get the implant are the ones who needed it, and those who didn't need it didn't get it. Okay? So we basically, at that point, were starting to look at the data. The data had just come around, and we're looking at a large medical centers data base and trying to analyze the predictability of this event. Okay, using the patient records, we built the model. We were very excited. The model was performing excellent. And we submitted. The submitted paper even won an award in a major heart association conference. It's AHA, this is the biggest heart conference that happens in US. But we never ended up publishing our work, even after winning the award at the conference. What it turned out in that case was that once we went back and started looking at the data closely and carefully, by actually physically looking at the data, we realized that the outcome that was coded, which was directly pulled through our data search, was 75% erroneous. So the technicians and the staff that was actually using in the language here, ICD-9 codes, were unfortunately not using the right ICD-9 codes as they were summarizing the information that was existing in the data set. Sure enough, when we started realizing it, we ended up realizing that although we were starting with a clinical question in terms of predictability of sudden cardiac arrest, the problem turned itself into be a methodological problem, where we ended up having to develop a method for reviewing data, because in the large data sets, we can't even review every single record. We ended up having to say, well, can we get a quality model in this case by just reviewing 1,000 patient records? And so in all of a sudden, as we were looking at the problem carefully, the entire focus of a problem from clinical analytics changed to methodological development. And fortunately, with OR training, we could manage to do that. And the clinical questions had to be revisited or had to wait for a much longer time because we wanted to get the methods done right. And I can say one thing, there's a lot of excitement in the US, and I'm sure there's some in India also and other countries where as the clinical data is emerging, we like to be the first to analyze the data and put out new information that could be helpful for patient care. But extreme carefulness is required as we try to analyze the data because of issues in the data itself. So because this is a conference on optimization and analytics and learning, I wanted to bring these two slides, this learning, so to speak, that I had very early on as I started work in this space, that before we populate our model, we first want to ensure that the quality of data that is going in to populate our models is well vetted out. And a lot of times, beyond building the model, time is spent first getting the data and then subsequently ensuring data quality. Okay. And this is more so importantly the case in healthcare. Okay, now I'm going to switch gears a little bit. I'll say, so we talked about data quality, and this is now going to lead into the theme of the rest of the little bit more technical talk. That data itself in healthcare is random. And the example here is of number of patients in a care unit that have been in that care unit at a specific hour throughout a week, superimposed over multiple weeks. So as you can see that, and this is real data from a particular hospital, where you see that there is a mean demand that is changing of what will be required in terms of, or in this case, the number of patients that are in the hospital unit. But then there's also a large confidence band around that mean demand that is non-stationary. So once we are presented with data like this, we want to analyze the data to see if we can extract information from it. Then we can use it to populate a particular question of interest. So in this case, the question of interest was how to staff the unit. And again, in the US, about half the cost of medical care goes towards personnel cost. Again, a large number of registered nurses care for the patients. They have a significant average salary. And there is a projected shortfall for that resource. And again, people have been looking at that issue and trying to fix it in multiple different ways. We got to it from the angle of trying to look at the staffing problem. As the cost is an issue, pressures are always there to hold the costs down, as it is the largest budget line item. And the implications of having overly optimized on cost, meaning reducing the cost too much, have on patient safety. So if you have too few nurses or physicians serving a unit, there will be two implications of that. One, the patient safety can be compromised, or we may have increased staff burnout and the staff dissatisfaction. And there have been studies on that. There's data collected where in the papers, people have documented that in hospitals, in nursing homes, and even in other settings, there's almost 20 to 40% burnout rate, which means that nurse who starts working in the profession after getting all the training feels like they want to leave that profession because they just don't feel the intrinsic energy. And that burnout issue was definitely compounded during the COVID days in the last 2 years or 3 years, and just came to the front. Okay, so now think about how the decisions are being made here. So typically, we have about, say, 8 weeks or 12 weeks of head start. At that time, we need to put together a plan of how many caregivers, nurses would be working a particular shift on a given day. As we get closer to the actual day of service, we could be adjusting our decisions based on the forecast that may be changing as we get closer to the decision point. Okay? Now, immediately, I was showing the data before. We have this data that is non-stationary, but we try to extract information from that data using analytics. And in this example, let's say if we have a list of forecasting tools that are available to us in say a package like R, and then what we want to do is try to see which of those could be giving us the best possible forecast. And again, the goal there would be to try to forecast demand in the future to minimize overall error. The lower the error in our forecast, the closer to the deterministic situation we are in our problem. But forecasts are meant to be erroneous, right? If we could perfectly forecast, then everything reduces down to a deterministic problem. Okay? Everything is known, all parameters are known. What, however, be the case is that there's going to be always significant error. So, and particularly in healthcare, we can't manage the demand. Think about an emergency department. People have emergency and they show up at the emergency room door, and we need to provide care. And similarly, providing care on the day of, on the very same day, we have demand, people walk in, we have walk-in clinics. You can't very precisely predict the demand of that walk-in clinic. Okay. So now, when we have a situation where we have a model that is trying to predict the demand, allocate resources based on the predicted demand, it naturally lends itself to a general framework of what we'll call a news vendor framework. Where in a news vendor setting, news vendor, like the classical OR model, you need to order a certain quantity, not knowing the demand. And if there is the order quantity is oversupplying to the demand, then we have some salvage value. Otherwise, we have basically a shortfall and lost opportunities. That has its own implications in the current setting. So now, on the technical part of my presentation, I just wanted to show a few things where once we start framing our problem, we are facing a technical question, and then that technical question is such that we can't just solve the problem by just throwing a off-the-shelf commercial package at it. We need to go deeper into looking at the structure of the problem, try to see if we can actually improve towards solvability of the problem, and subsequently establish the value of building more complicated models. All right. So in a big picture sense, what we have is in a particular, we're trying to build these schedules. These schedules follow a certain pattern. Okay. There are some patterns that are going to be there so that we can actually follow the duty rules that nurses have to satisfy or the doctors have to satisfy, based on which whatever feasible patterns may be there over, say, a 12-week of plan that we will be creating. And then as we get closer to the day of service, we would be adjusting to those. And that, in this case, just so happens, based on the duty rules, there could be 56 or so adjustment patterns. Okay. Now, these patterns can be built of 8-hour shifts, 10-hour shifts, 12-hour shifts in the setup. So now, the overall modeling framework here is that we need to make a here and now decision as to plan howsoever many nurses, for example, will be working specific shift. And then subsequently, as we get closer to realizing the true demand, we adjust to either get one more nurse or one fewer nurse, or have a nurse go home 2 hours early, or ask a nurse to stay for 2 hours longer, so that we can do a better supply-demand matching at the time of care. Now, there is a cost associated with adjusting our decisions closer to the date. So there's an original plan, and then there is a subsequent adjustment to that plan. And that subsequent adjustment to the plan essentially will result in either getting additional staff by paying overtime, or letting a staff that was already there to go home and not or do less productive work, so not recover the full value of that staff's time. Okay. So in this case, for those of you who do not know stochastic optimization or stochastic programming, we have a quote-unquote first stage decision, which is our plan, and that decisions are variables xi in this model, whereas we have some adjustments that would be happening in the future, and those adjustments are decisions yj's plus and yj minus, depending on whether the up adjustment or down adjustment is happening. And overall, these adjustments should be then somehow be as close as possible to getting us the actual demand to be served. Okay. So this modeling framework is a very, very generic modeling framework. What you're seeing here is its application in the context of staffing problem. Now, there are obviously costs associated with things. So for each shifts, we have a certain cost. We have the penalty that we're going to be paying if we are overstaffing or understaffing, and those are Qs in this model. And then eventually, from a model consistency perspective, as we look at the future, there's a penalty R plus and R minus, depending on whether we are still a little bit short or still a little bit long because of the integrality requirements of the staff that we can be having. Okay, so this is a mouthful, and this is a problem where this matching needs to happen for T in our time horizon, capital T. So this could be every hour of the day of the week. So that's be 24 times 7, at least that be duration. Okay. What's interesting here is in this objective, we have a random evaluation, one based on what will be the future observation of the true demand at the time when we are planning. And the model itself is based on taking an expected value of this future cost, which we call a recourse cost. So there's a cost that we'll pay here and now, and then there'll be a cost they'll be paying by taking this recourse action based on what the actual scenario that gets realized. And that scenario is generated by omega. Okay, and this is the expected value calculation. So we have cost for plan plus an expected cost of recovering for the deviation that can be resulting from what would be the ideal from the plan perspective, because our demand realization is different from what we maybe our mean forecast. I'm going to have to stop annotating because otherwise. So I hope this model is clear. And this model is something that we're going to come back to at least for several slides. Okay. So for those who know stochastic optimization, these models can actually have can be formulated very extensively as an optimization problem. It's a 0, 1, or in this case, it's a mixed integer optimization model. we could, that's a brute force remodeling. We could take this, give it to a solver, and try and hope that this is going to come back and solve the problem. Unfortunately, that does not work. Okay? So just to give you a sense, for a model that involves 1,000 demand scenarios that will be generated, and I'm going to make some comments on that a little bit later. This problem that I've just written here is going to have 1.37 million integer variables and about 1 billion continuous variables. Okay, you look at a commercial solver like Cplex, even with 10 demand scenarios, that solver will fail to do anything with it. Okay, so now we step back and say, what can we do about these problems? Again, this seems like a realistic model. Can we really build our mathematical understanding that can help us solve this problem in a more intelligent way? So we go back and look at the structure of the problem, and specifically, we can, and I'm going to jump to conclusions here in the interest of time. Specifically, what we can do is in the area of integer optimization called, something called inequalities that we generate in integer, when we're solving integer optimization. Now, in this case, what we could very specifically claim was that there's a certain type of parametric inequality that we can add in this model very systematically. This was very novel at the time, where once we add those inequalities, after adding those inequalities, we could essentially drop a lot of integer variables that are in the model from consideration as integer variables. You could just turn them into continuous variables in the problem. Okay. So again, the technical part of it is that this is something called mixed integer rounding inequalities, whose generalized counterpart here could be then added, and looking at the structure of our specific model, we could show that this generalized mixed integer rounding inequalities would strengthen our model's formulation to the extent that we don't need to explicitly require integrality of the future variables that are appearing, one corresponding to each scenario. Okay, now with that, once again we can write the model as an extensive formulation, except a lot of the integer variables are no longer integer; they all become continuous. So remember, before we had 1.3 million integer variables. Now we've got only 3,900 integer variables. Because there's a dramatic reduction in what be possible. And at least in this case, you could solve a problem with 10 scenarios, 10 random realizations of the future. But then we say, okay, now we at least made some progress. Can we do more and more and more? Okay. So we dig deeper, and we try to understand the properties of this general two-stage mixed integer stochastic program as it was as it came up in a context. That property I just was talking before could help show that our second stage model could be this expected value function can just be can be thought of as a piecewise linear convex function whose outer approximations one can build based on the subgradient calculations of that function. Okay. Now, with those concepts, one can then look at various versions of the so-called L-shaped methods that take our expected value recourse function into a constraint and tries to build these approximations. Something called Bender's cuts for those who know this kind of this direction of optimization language. So we could generate the Bender's cuts and what's called optimality cuts towards building an algorithm that will systematically solve this problem, which now is reduced to having just the first stage here and now decisions that are integer valued, combined with only a handful of continuous variables. Okay. So the idea here is that as we add these inequalities, we are getting tighter and tighter relaxations of our problem as we approach towards optimality. Okay. Now these things still turn out to be slow. There's a version of this where we call single cut approach. We can add multiple cuts, and we sort of generate a lot of computational experience as we put in our effort towards solving these problems. Okay, and very quickly you realize that the number of vendors cuts that we add at each iteration has a significant impact on our ability to solve these problems. We then go into and develop a cut management system that will help keep track of these vendors cuts and looking at different scenarios and scenario aggregation. So a lot of sort of if you like, algorithmic engineering that goes behind in terms of how to implement these problems. Multiple strategies for partitioning these future scenarios one would want to look at. One would want to start our algorithm in different novel ways. All of those things come together eventually towards solving the problem, but you still don't find something powerful enough. So you say, okay, I'm going to go one step further. I'm going to try to implement all of this in a parallel computing environment. The parallel computing environment in stochastic programming, the second stage decomposes with the scenarios. So we can extract information on each of these scenarios one at a time as they're solved in parallel towards generating aggregate cuts and adding those to the so-called master problem. Okay. Now, that's all the technical detail. But then you now come back to the real problem. So there are certain shift types that are there, as I mentioned before. So the 12-hour shifts, 8-hour shifts, a mix of 3 of 12-hour shifts and 8-hour shifts and so forth. So all of those with full-time and part-time staff gives us all the shift scheduling pattern in this case. They're all this additional machinery that is there in the optimization literature called thin direction branching, or some things on which interesting theory exists. So as we try to solve these problems, say, well, we still have to make them more and more efficient so that we can generate practical insights from models that'll get solved. So in this case, we kind of leverage that idea to put extra constraints that mimicked this notion of thin direction, specifically introducing new variables that represent the number of workers in each employment type or each number of workers in each shift type. We could then just branch on that number of workers to help first look at just limited slices of the of the feasible set, subsequently restricting our search on those slices. Okay, so again, I've talked a lot in the last 10-15 minutes about all the technical jargon. I mean, all of this is obviously in a technical paper, but just to step back and give you a sense of what happens from a computational perspective. We have the original problem that had 1.3 million integer variables, 4 billion continuous variables. That problem was totally intractable. With all of the improvements, we could bring it down to solving it in 5 minutes. With our initial solutions happening in 40 hours after getting our first theory in place. Now, once we had that, we could experiment because now we could solve the problems on a parallel computer in 5 minutes. We wanted to see whether there is a value in generating more scenarios into the future. We could clearly see that there was value and that there was a law of diminishing return there. about 1,000 scenarios was sufficient. Was there a value in generating the stochastic solution compared to just taking the mean forecast and looking at the deterministic solution? We could clearly establish that value. We could then study whether there's going to be, if we knew the perfect information, we knew the actual demand, how much would be the expected value of that perfect information? About 5%, and 5% in these cases is significant. We then went and did the study on how, what will be the value of stochastic solutions that we're generating as we find our forecast environment to be more and more uncertain. In other words, we're having more and more forecast errors. So the conclusion here is that as the forecast errors increase, our value of the stochastic solution increases under different cost regimes. I will not bore here, but there's some details about how different algorithmic strategies can make problems tractable versus leave them intractable. And thin direction I mentioned before, there's value in that against some things that speed up by a factor of 2. So by the time you multiply these factors, something speeding up by a factor of 2, something speeding up by a factor of 4, parallel computing theory, you get something that was first from intractable to 40 hours, and then almost 300-fold improvement to solving it in 5 minutes. Okay, so that was one concept in one particular context I could talk about, but that's the paper number 2 here. It was published 5-7 years ago in OR. But then this has led to a sequence of future studies that I have done with my PhD students and postdocs, where we looked at these problems, we looked at their structure, we developed algorithms. The last in this series is where we looked at the problem in the context of conic optimization, where we actually looked at a location problem whose natural formulation was a 2-stage stochastic conic optimization. And so correspondingly, there are a sequence of publications and so forth. And again, there's one within this framework that is still under review, and where the application was for service center locations for the pandemic vaccination locations. Okay, now, in summary, as I know I've been talking, so in summary, I would say I've just given 1 or maybe 1.25 illustrative examples in the limited time I had. The significant opportunities for optimization, learning, and analytics in healthcare. I have probably a dozen papers on different types of facets on this that I've done over the last dozen years or so on completely different application domains. In addition to data availability, data quality is a very significant issue. I think we need to be very cognizant of that. Very careful consideration of data quality and availability can lead to new novel methods or adaptation of current ideas, which is where some of the cutting edge research can be happening, methodological research can be happening. Now, incorporating uncertainty in decision optimization framework is useful in improving system performance. In this case, I've not shown all the slides, but we very clearly demonstrated that the solutions in this way compared to what was being implemented in practice or what would have been coming from the deterministic approximations were improved by about 5 to 7%. And 5 to 7% cost improvement at least in the US in healthcare is very significant. Okay, now the developed frameworks can lead to new theories. And there's a couple of papers I mentioned in the previous slide. They're like really digging deeper into the theoretical constructs that can be, that one studied thinking about solving those problems that be potentially coming from other problem domains. In this case, for us, we started with staffing, and the next one we ended up doing within the same framework was in location. I think with that, I'm going to stop. I'll give some time for questions, but thank you very much for inviting me, and I hope I can answer if any or many questions you may have at the moment. And of course, I'll be available even by by email or set up a separate Zoom call if you like to discuss any of what I've talked further. Thank you.
Thank you, Professor.
I'm sorry, I can't hear you. Hello?
Thank you, Professor Malhotra, for such a wonderful lecture, enlightened us a lot on the stochastic optimization in healthcare. And very rightly, you said that healthcare investment and mortality and so their societal impact, and it relates to the patient, doctor, nurses, and facility. And when we talk in optimization, it is a man, machine, and money. The modeling and analytics definitely play a very crucial role while forecasting such healthcare system. And it is very important to forecast some ideal relationship or some relationship in order to meet the demand and supply in healthcare. And it need to be considered, that is doctors, staff, nurses, and managerial staff of the healthcare system, plus their facilities, along with the location altogether. So is there some basic to forecast how to meet such demand and supply? And recently we have encountered with this COVID-19 experience. So it is a very huge gap, and a lot of study need to be done in this area. And we should develop such a model where we can ideally forecast the demand and supply to fulfill this healthcare system.
I think that's a very great point. And of course, COVID pandemic example was very illustrative. I did a paper very early on in the COVID cycle about sharing of ventilators when ventilators were in short supply. And at that point, it was the first 3 weeks into the COVID pandemic, and the forecasts were extremely hard to come by. And this was a problem that was to be done at the national level. We were looking at how ventilators across the different states within the country could be shared to save patient lives. And back then, ventilators were in short supply. So to your point, I mean, forecasts are meant to be wrong, right? They will almost never be precise, but nevertheless, forecasts are there to reduce uncertainty in our crystal ball. Right? So we have a crystal ball. I mean, we don't know what the future is. We're trying to project what that might be, but the more closely we can be projecting it with lesser error, the better can be our plan, right? So if you think about pandemic, and if you could have forecasted, say, the Delta variant and all of that early enough, or even say within 2 weeks before or 3 weeks before the actual full-blown sort of exposure of the variants or even the early viruses, we could institute some of these policies well in time. So I think that was a great example. I think India is pretty forward-looking in that, and to some extent US too. So as very early on in the context of pandemic, the projections were that there will be significant short supply of the resources. The policy of law, and there was very little information on how, what will be the R0 on the virus that is spreading. The very early decisions of lockdowning in, let's say, in city, New York City and the state, and subsequently across the different states in US, and of course a few days later in India and so forth. It was very clear when we were looking at our analysis on ventilator sharing in that setting, that if that lockdown had not happened, within a very short period of time, there could have been huge mortality, which just got prevented because somehow the virus spread got slowed down through the lockdown mechanisms. And of course, once you start developing vaccinations and start seeing herd immunity, some of the dynamics changes. But early on, when we are in resource constrained environment where every resource matters, our
Definitely,
ability, so our ability to predict early and more accurately really matters, and then plan accordingly.
and this kind of forecasting is need of an hour, and you are very much senior to me, sir, and also you are familiar with this our country India, and you are also from the India. And if you see the Indian perspective in healthcare, that is still a challenge, although the Indian government is investing a lot, but to provide the facility or to reach at the end point to meet the demand and supply, can you?
I need to, yeah, I guess that's a very
So
good
it is
question.
a very big challenge if you see this Indian perspective for this healthcare system.
Your point is very well taken. In fact, one of the location papers that I had originally was motivated from, in New Delhi, there is this Mohalla clinic model. So how to locate the Mohalla clinics is how that one effort was originally motivated. But, the way to think about healthcare in India is to think about healthcare in US that was 30 years ago.
Yes, sir.
Okay.
Because
So
geographically scattered area is also play a crucial role while
fragmented information, different languages, data is still an issue. People don't pay close attention to their care. There's a lot of dynamics that goes on. Of course, I mostly focus on very technical part because of the nature of the conference here. But I mean, it is a so can it be done? Let me put it this way. I think the answer to that question is yes. Okay.
now I request the audience if you have some suggestion, feedback. Yes, please. Sir, there is one question from audience.
Sure, please.
Hi, you can come from here.
Thank you, sir, for your talk. I just want to know, since we are working in news vendor model and we have seen so many applications of not stuffing problem and news vendor model, but in some recent papers, when we are looking at the data, so I have tried to download the data, but those data are very insufficient, means density estimation is not that good. So can you, means I have a query that can you suggest me that from where do we can get the not stuffing data?
From where can we get what data?
Not stuffing data means a good amount of not stuffing data.
Good amount of, I'm not sure what I'm picking that phrase here. Good amount of non-stopping or non-staffing?
Not stuffing, not data related to not stuffing in some country or not stuffing.
Yeah, so he's talking about the staffing of nurses.
Nurse staffing data. Okay, so in terms of the actual staffing, I can tell you the data that we actually eventually, so there's a patient volume data that I have. I mean, I can even give it to you, right? Yeah, that's not the issue. But the actual staffing that was there, that's very proprietary to the hospitals, right? But because I was in the hospital system, right? I mean, I know the people. We could actually write the queries and pull the data from the EHR department, from the records to see how the staffing was planned. I'm not sure if I'm answering your question, but all the data was electronic data, and we had direct access to the entire database. I just mentioned about the patient volume, and I skipped some details there, right? In terms of how we did the comparisons. My PhD student wrote SQL queries from the engineering campus into the hospital data system, for which we had full access. to know exactly how many nurses they had for each shift of each shift type, so that we could actually make a head-on comparison. And some of this was presented to the complete hospital leadership at the level of chief nursing officers and chief operating officers and so forth.
Thank you, sir.
So if that was your question, I hope I've answered it. But to work in healthcare, oftentimes you also need to be embedded, sometimes with the leadership, who is actually really vested in the problem. I mean, they really want to get the problem solved because that's a problem they are facing. And fortunately, in my case, as that particular project I mentioned had exactly that connotation. I could have presented some other projects. Some things I'm working in transplantation space where exactly the same thing. Because the leadership there is very much interested, they're willing to listen.
Rightly said, sir. Now, is there any other questions from audience? Are there any other questions? So, sir, again, we are very much enlightened us that you deliver such a knowledgeable talk over here. And on the behalf of this Heritage Institute of Technology, Operation Research Society of India, we are very much thankful to you, sir, for providing us the insight about the healthcare and analytics that is the need of the hours. And we have to think more and more about to forecast such a system that caters the need of the population.
True. And I'd be more than happy to help the team there in whatever way possible, should there be a need. Because as I said, right, I'm from India. I like to make sure that whatever I'm learning here in US, we can take it and help people in India to make that improvement of within whatever scope that's there.
So
Okay?
with
Thank you
that,
very much.
we are very much thankful to you, sir, and hope that some scholars from India and other places will join on this healthcare and analytics. Thank you, sir.
Thank you. Thank you. And you have a very good day. You have a good
Professor
weekend
Malhotra.
also. Yeah.
Well, we are thankful to Professor Sanjay Malhotra for joining from Northwestern University, Evanston. This session comes to an end, and I would like to thank Professor Avinash Kumar for chairing this session. And we are running a little late, so very brief tea break at the executive hall, and please reassemble within like 5-7 minutes. Okay, and we will start off the next session.
You have a good day. Thank you very much.